is our privilege, certainly, to have Professor Henri Bismuth with us today, and it was only very logical to have him to talk about liver surgery up to the robots. And it's also very clear and that if you ignore the past, there is a good chance to fail in the future. It's been done by many people, including Mr. Confucius, a long time ago. So how I introduce Henri Bismuth. Everybody knows him. I'll say just a few words. He's born in Tunisia, moved to France, and early on, that was novel, did a lot of research. He is an intern, a very competitive grant that he had 78 to 82. Then he was involved also in research at Kremlin-Bicêtre here in Paris until he developed in the 90s his very famous center. So he has contributed to so many things. There are very little things that we've done that the idea came from Henri Bismuth, and he's really one of those who thinks out of the box. Before the other one, try to find solution, and in addition to that, I think what's very important is not just to do it for himself, to make the world, to find, to publish, that it's communicated, the positive and the negative results. So the first things, and I think he has insisted on that, is the liver. Not long time ago, this is all recent, this history was just a solid organ and it bled, please don't touch it. Mortality was extremely high, so where do you go? You learn the anatomy. And he referred to Quinault, another French, who an anatomist, to describe that, trust in that, and learn and build the skill in surgery from the knowledge, from the anatomy. Introduced, now that's routine. Nobody almost is touching a liver today without having an ultrasound. That was very novel at that time, to take an instrument for radiology, go to the OR, put on the liver, and try yourself to learn. That has been a dramatic change in the way we were doing surgery. And another credential, in addition to that, to put people together in '96, this is an editorial that was written in the Annals of Surgery, at that time with David Savis on brain, European surgery, which was well behind the American surgery, or at the same level by creating the European Surgical Association, where we have today annual meeting and some very good paper from Europe published on a regular basis. So to show to the world also what is going on in Europe, so that was certainly a big achievement. I can go along, and I will not do a conference. We know, I'm talking today, the downstaging at a time when we did not have the chemotherapy. That was very novel. That's some tumor that will not touch, never. Well, you can do something before, operate, and have a good outcome. Needle restrictor, everybody knows, his name is associated to this, and every complication that I'm aware of, or classification, is in fact based on this system. In transplant, many novelty that were done, and I think we have three names that come as a pioneer: Tom Starzl, Rudolf Pickelmeyer, and Henri Bismuth. All together was competing to advance the transplantation. There has been many, I will not list all the things that were done. I mean, the in situ split, reduced size liver, and many aspects were done. Now, even further, he built, and many of you know this Corbus, this institution dedicated to liver disease, still unique, and this is not only efficient with all the people that you need to do liver surgery inside, but it looks good. Its architecture is art. So what it looks good usually work also better. Now, last things, the legacy. Many people have been in Corbus as followers, long-term visitors, etc., and they have all very large recognition, and there is this group that in fact is involved here and endorsed this meeting called the Compagnon, which cover all the continent. People are enthusiastic and now take even advantage of all the Zoom to regularly meet and discuss cases among experts in the world. So that become a real society of experts in liver surgery, and that was, I put this picture here, recently where with Professor Dong, I think he's in the room, in China, we've been a few times, also with this correlation, this collaboration between the France or European surgery and China. I stop here because I could talk a lot, but I'm very excited to have you here, Professor Bismuth, so please welcome. Thank you.
As you see, I have a very good friend, and Pierre, Very good friend, thank you. Yeah. Yes. We think about the history of liver surgery. Indeed, it's not so long. Look, really, it starts the 19th century, not so long, and by some report on trauma in battlefield, very poor treatment. And the first case of elective resection was made by Lewis, an Australian surgeon. What he did, excision of an adenoma exteriorized with ligation of the pedicle. Unfortunately, the patient died of bleeding. The real first successful elective liver resection was made by the famous surgeon, Karl Logenbroek. You know, he did 4 years before the first cholecystectomy. What he did? Sorry, I have to go back. How to go back? What he did in 1988, he resected tumor of the left lobe, also ligation of the pedicle, but recovery. Unfortunately, examination of specimen, normal tissue. It's a pity. The first two cases, one death and the second one, a bad indication. Now, at the beginning of the 20th century, some report of liver resection, but badly made, wet resection, irregular anatomy, and indeed, we must wait this date, the 50s. In the 50s, for the first time, there was a real anatomical resection published by Dr. Jacob in France in 1952. He described very well anatomical division. It was right hepatectomy with ligation of the vessel, of all the vessels outside of the liver. I must quote also Totatung, a Vietnamese surgeon, the French school, for he did also anatomical liver resection, but took it differently. He knows the line of division, the country line, and he opened the liver directly going to the vessel. That means he ligate the vessel inside the liver. Of course, you have to be very quick with a lot of clamp, but it was also anatomical liver resection. So this was for the resection. The same decade, in the 50s, you have the anatomy. First, Goldschmidt, in America, he added to the country line the sector he called segments. That means the liver is part in 4 segments. At the same time, and the same year, Claude Quinault published his book, a book called The Liver, Anatomical Study and Surgical Study. Quinault was a surgeon, but mainly an anatomist. He worked on casts. He did 84 casts with color. And you see here, it's a nice one, the 4 color or the 4 sector of the liver. In yellow and red, the left. In blue and green, the right. And it studied perfectly well all the line of division with a lot of abnormalities. You know the principle, you know, the liver is part in 4 by the 3 hepatic vein, and each sector, called sector, is irrigated by a branch of the portal vein. This is the principle of the anatomy of Quinault. And it puts segment. And this is to the original. Putting, as I showed you yesterday, the center of the liver, the spiegel lobe is 1, then clockwise 2, 3, 4, 5, 6, 7, 8, and we have 8 segments of the liver. It was nice. We have the segment, we have the vein, we have the line of division, but unfortunately, changed nothing in liver surgery. Why? For at that time, we have no way to find small tumor. There was only, I remind you, the scintigraphy, which is a rough technique of imaging technique, only to find large tumor, and we have to wait that the patient is symptomatic with fever, pain, jaundice, to do liver surgery on him, and were, of course, only large tumors. At that time, I may tell you, the surgeon was afraid by the liver, this globulous organ, full of blood, and when you touch, you have a risk of mortality. It was published at that time, a series of right hepatectomy with 50% operative mortality. Can you imagine that? And we have to wait the very beginning of liver surgery. It was the preliminary beginning. The very beginning was the 80. Why? For the first time, we have imaging technique of the liver, which is ultrasound. And with ultrasound, we succeed to find small tumors. 2 centimeters, like this one. 2 centimeters is ideal to do segmentectomy. And the segmental liver resection starts. I published this paper in 1982 that I call Surgical Anatomy and Anatomical Surgery of the Liver. Objective was to let know the anatomy of Quinault, which was totally ignored, mainly by the Anglo-Saxon literature. And I published this. However, I did a small change. Why? You know, Quinault described on the right the antero sector and the posterolateral sector, putting the segment 6 and 7 laterally from segment 5 and 8. Indeed, Quinault was working an anatomist on a table. He put the liver on the table and inject the liver, the cast, on the table. That means that he described, for instance, the right scissura was 75%. Indeed, when you put the liver in the patient, it's not like this, and the right scissura is almost horizontal. And knowing that, or I experienced that in the patient, I modified the scheme of Quinault by putting the 2 posterior segments of the right totally behind the anterior sector, which is the real position in the patient. Now, in this paper, I said, and this was, I think, today considered like a little arrogant, I say, time is finished. That you have to do only atypical hepatectomy and wedge resection, you have to do anatomical resection. And to illustrate this, in the same review, we published major and minor segmentectomy, showing that it was possible to remove each segment independently. We were in 1982, and I think this is the real beginning of the modern anatomy, what's called the segmental anatomy of the liver. The second pillar, first pillar is anatomy, second pillar of liver section is intraoperative ultrasound. This was introduced in 1984 by a Japanese surgeon, mainly Makushi, and really intraoperative ultrasound allowed the surgeon to see the vessel inside the liver, to see the tumor, to see the relationship between the tumor and the vessel in the own liver of the patient he was doing surgery. It was not the book that he transposed in the operative field. It was the real liver. He was seeing inside the liver. This is why I say the liver is transparent. Looking at the vessel and looking at the hepatic vein, you look at the line, anatomical line of division of the liver. And looking at the branch, also the segment. With this tool, we start to do, at that time, real liver surgery. And this is why the first concept of liver surgery was the liver is vessel surrounded by parenchyma. And objective is to find the vessel. That means to remove the parenchyma to find the vessel. In the same issue of World surgery, I spoke about the finger fracture. At that time, finger fracture, the way described by Lin, used by Tontatoon to open the liver. But I considered the finger was too rough, And I say, why not to use a small clamp like the Kelly clamp in order to crush the parenchyma slowly, gently, in order to fight the vessel, to coagulate the small one, to ligate the other one. And this was the beginning of what I call teleclasy by position of digitoclasy. So, objective for resection is to go to the vessel to achieve this digitoclasy, teleclasy, and then came the ultrasonic dissector, the CUSA, which was very next. Now, going to the vessel, opening the parenchyma, you need to control the bleeding. At that time, you have to do that outside to the liver. The first technique described was by Pringle. He described for trauma. That means when you have a patient with trauma, it was the beginning of the 19th century, he said, go immediately to the hepatic pedicle and clamp with your finger the hepatic pedicle in order to control the bleeding. Of course, this was adapted for liver surgery, the Pringle maneuver replaced by a clamp, and then you may see more elective clamping on the right by clamping the right branch, by clamping the segmental, the sectorial branch, or even a segmental branch. That means we may have all the different way of clamping the vessel. We know the line of division, we have ultrasound, we know the different way of clamping. At that time, we may do liver surgery, anatomical liver surgery, without the risk of bleeding. Now, in the early 2000s, new tools came to cut the parenchyma while doing hemostasis at the same time. Laser is not a good way, Villejuif, tissuing, you know, or radiofrequency linear or by the abductor. At that time, we changed the concept. The liver is parenchyma with the cell inside, which is really what is the liver. And now we describe, it is described not only by me, all the type of liver section, what we call lobectomy, this is the classical anatomy, morphological anatomy, left lobe, 2, 3, right lobe, which is 4, 5, 6, 7, 8, plus the Spiegel lobe, which is the third independent liver that we may remove with the left, with the right. Saying we may do right hepatectomy extended to segment 1 and to segment 4. And we have the terminology to describe exactly what we are doing. However, if we go back to this, I spoke about the control of the portal, but about the hepatic vein. You know, usually anesthetists, when they know well what is doing the surgeon, control la cava by lowering the central pressure. It is enough in the normal surgery. But if there is contact of the tumor of the hepatic vein, there is a risk not only of bleeding but also of embolism. At that time, you need to control the hepatic vein. The first technique was the total vascular exclusion described by Henri, as you see here. Really, it is a very nice technique, a very useful technique that you may use in this kind. You know, this patient, the young patient, was sent to us for liver resection. For it was a fibrolamellar benign tumor, of course, huge, and you see the close contact of the tumor with all the portal branch which was extended. But benign tumor is not involving the vessel. It is outside. You may do removal. You don't need to remove the parenchyma, only to do a large nodulectomy. And with the technique of total vascular exclusion, you may control for 1 hour, and you see in this patient, we remove only the central tumor without any part of parenchyma resected. But we need to have 1 hour. After 1 hour, you may have a suffering of the parenchyma. At that time, it's better to do what was described by Fortner in 1974, not only the total vascular exclusion, but also the cooling of the liver by a bottle like this one, or by a pump, like in the liver transplantation. But by this technique, if you bring the liver at 4 degrees, you may have 6-8 hours to do mainly a vascular reconstruction. I give you an example here. This kind of malignant tumor involve vena cava, involve the hepatic vein, the only hepatic vein, the left, but the left parenchyma is normal. This is not contraindication to do resection, but of course you have to do sometimes resect the vena cava, and sometimes also to resect the termination of the only remaining left vein, reimplanting in the graft. This kind of extreme liver surgery show you all the scale of hepatectomy that the surgeon now may perform, from the segmentectomy, even subsegmentectomy, hemihepatectomy, extended hepatectomy, and extreme liver surgery. Now, these are the means. What are the objectives of liver surgery? Of course, to remove the tumor, to remove the disease, and to decrease the morbidity and the mortality. The technical complications are the three, and I call them the green, the red, and the yellow. The green is the bile. The bile may be controlled. You may control at the end of the operation by injecting methylene blue in the cystic duct, waiting time to see if there is a leakage of bile and suturing it. Bleeding, you may control. When I ask, what do you put on the liver to control the bleeding? I say, time, wait. And the third one, which is more severe, is the yellow one, ascites. Ascites means liver insufficiency, or you damage the liver parenchyma by a too long clamping, or there is no enough remnant liver. And this is serious. For the mortality, I show you part of our experience here, that only to show you things. One, indication is important. You see trauma, and as you see on 30 patients are risky hepatectomy, where we are more than 5% operative mortality, that means during surgery and 2 months after surgery. But if you look at all the other indications, including colorectal liver metastasis, which is the main indication, for 2,000 cases, you have 1.5 operative and perioperative mortality. I may say this is today acceptable and the objective in expert liver surgery. But there is better than this one, and Makushi published this extraordinary series. I think this is the gold standard. 0 on 1,000, 0 mortality, 1,000 liver resection. What it means? You may achieve it, not only by the surgeon, by the preparation of the patient, at the follow-up of the patient, what is called precise liver surgery. It may be achieved, and this is the goal. Now, the second objective, I show you the first objective. The second objective is to increase the indication. It's not enough to say, oh, I do only surgery in the patient, we may do surgery for liver tumor, for any other disease. In tumor of the liver, malignant tumor of the liver, even today, the only chance of the patient is to be resected. That means you try to increase the number of the patients you have to increase. And what you have to do, neoadjuvant treatment, to change the tumor or to change the liver. To change the tumor, we saw that in 1996, publishing this series of what we call resection or non-resectable. This was a little aggressive title to have the paper accepted in Annals of Surgery and showing the picture. Indeed, we did nothing. The patient we cannot resect with the chemotherapy, but we follow the patient. And following the patient, we saw that the tumor decreased in size in the way that it is resectable. That means by the neoadjuvant chemotherapy, you change the volume of the tumor, only the volume, and at that time the tumor may be resected. I may tell you that the same year, at the ASCO meeting, there was no one case, no one report of tumor treated by chemotherapy. Of course, after there is an explosion of cases. And it was described for the liver, it extends to the other tumor of the GI tube. The second objective is to increase the liver parenchyma. Sometimes contraindication of liver resection is due to the small remnant. Like here, the tumor, you don't see the tumor. Tumor occupies the right liver per segment 5 and, segment 4 and 1. That means 6 segments of the liver. Only 2 remaining. If you calculate the volume is 30%, but look, the patient has 18 courses of chemotherapy, and we know now that liver is not normal. If liver is 50% of its potential, that means the remnant is not 30%. Functionally, it is 15%, and 15% is not enough. But we know now, we know by the portal vein embolization to atrophy one part of the liver, the one you have to resect, and hypertrophy the other one, like here. Of course, there are other ways to do that. You know, of course, the HAL procedure, which is very nice to increase the speed to have the hypertrophy, and more recently, the double sequential portal and hepatic embolization in patients with tumor. So we have means now to change the volume of the tumor, to change the volume of the parenchyma. This is not only technique, it's adjuvant of the technique. And all this had to be taken in consideration by the liver surgeon. Now I go to the 10 last year. Of course, laparoscopy appeared earlier. At the beginning, I was a little concerned by the laparoscopy. For laparoscopy at that time was performed by laparoscopic surgeon. Strange definition of surgeon, laparoscopic surgeon. They were doing anything, even the liver. I remember one surgeon published a big series. Majority of case was asymptomatic benign tumor. And I said to him, I remember it was at the American Surgical Association meeting. He was proud of the small incision. I said, do a biopsy of the tumor. And the fine needle biopsy puncture is smaller than the incision. No need to remove an asymptomatic focal nodular hyperplasia or angioma. But it changed. It changed when laparoscopy was performed by liver surgeon after the Morioka consensus, and at that time I recognized laparoscopy used by expert liver surgeon has excellent result, of course, going until what is the more risky liver section, that means the living donor hepatectomy introduced by Daniel Cherki and our chairman Olivier Soubran. This is really the illustration of the safety of laparoscopy in liver resection. Then there are some, I will say, tools. Some are gadget, some are useful. I let you know, decide what they are. A 3D construction, augmented reality, a nice image, okay? But you may use it or not. This is very useful, and I think it helps to do a very precise liver resection. And of course, I arrive to robotic. Let me tell you what I think, more and more today. I have the feeling that robotic has the objective of improving open surgery, to do more precise open surgery with, of course, objective of decreasing the risk of the hepatectomy and with better results. If you succeed to do that, I may say that this is a new step, a new improvement in the history of liver surgery. Now, I would like, by my slide, to define the robotic liver surgeon. Yesterday you spoke about training. What has to be trained the robotic liver surgeon? We have to be trained in anatomy, echography, vascular surgery, microsurgery, immunology for transplant, if it will transplant. Of course, hepatology. Hepatology is mandatory. Oncology, laparoscopy, yesterday you have a debate about this, and of course, robotic. Robotic is small. Training of liver surgery is much important and longer than training in robotic. Now, I define robotic, I define liver surgery. The last word for the surgeon. I would like to define the surgeon. The surgeon is not a technician. Technician is the one that manipulates tools. For me, he's not operator, knowing all the techniques. The surgeon is the one who tries to cure the patient. Robotic, il mean, objective is the patient. That means that you have to adapt the mean to the objective and not the objective. Thank you.
Thank you very much, Professor Bismuth. So we take a breath and time for a coffee break, and we will get back to 10:30 for the next session.